Hello, everyone. We are going to talk about BPH today, the pharmacotherapy, the medications that you will be prescribing to treat BPH, benign prostatic hyperplasia. Not a super long lecture here, but a lot of good stuff going on. We'll want you guys to make sure you know first line, second line, third line, etc. for BPH. Just a little bit of background here. This is an issue that will concern your male patients, and particularly older male patients, because like I was told in pharmacy school, all of us men we're sitting on ticking time bombs, and I freaked out. And I asked if there's anything we can do, and all the women in the class laughed at me. But anyway, so yeah, men have to think about their prostates getting bigger as they get older. And this causes some symptoms here that are listed here, just things that aren't that great. And these medications can help treat that. First off, there's some behavioral modifications, like with most things we talk about. First line is usually going to be your behavioral modifications instead of jumping to surgery or jumping to pharmacological agents. So definitely go ahead and read through this. For example, the benefit of voiding in a sitting position rather than standing. So that means sitting down to urinate. Some other behavioral modifications include avoiding fluids prior to bed or before going out, reducing consumption of milder diuretics. So those are things like caffeine and alcohol. And then double voiding, which just means to empty the bladder more completely. So just meaning, you're sitting there, just void, and then just make sure everything is out. This is what I do. I sit on you. Sit on you. No, this is Tim and Eric. But this just reminds me of, did I have it hyperlinked? Yeah, Tim and Eric video here may not be safe for work. NSFW, I guess. But I don't know if anyone's a Tim and Eric fan. But this is what just reminds me of what's sitting down to go to the bathroom for men. So, and that's not on the test. Don't worry about that. You don't have to worry about that video. The other thing to remember too with behavioral modifications is, like with other diseases, that you always want to continue these even though you start the pharmacological agents. So that is something to think about. The other thing too is, speaking of pharmacological agents, definitely pay attention to this next slide, because there are medications that men should avoid that can make their symptoms worse. So it's a big list here. Don't worry about memorizing this for my exam, but just know, definitely read through the list, know which classes of medications are, potentially associated with urinary retention. And just the main take-home point of this slide is that it hits a lot of different patients, because you'll notice it's a lot of different classes of medications. A lot of different things are, a lot of medications, unfortunately, can be associated with urinary retention. Initial medical monotherapy. So this is people that have the mild to moderate, which the IPSS is right here. It's the International Prostate Symptom Score. So IPSS, which I don't know if they were trying to be funny when they made this up, but I read it as IPIS. I don't know if anyone says that, or, I mean, definitely, I know professionals is a big concern, so I wouldn't go around saying that to your preceptors and stuff, but maybe if you guys are with a urologist or something, I don't know if they pronounce that IPIS, but I do. So that's just my thing. But like I said, it is technically unprofessional, but IPSS just helps me remember, right? So initial monotherapy is with patients that have the less than 8, which is considered mild to moderate, 8 to 19. Again, with this table here, it's more FYI. You do not need to memorize the IPIS scores, the IPSS. Sorry, I'm trying to keep professional here, not laugh. But you don't have to memorize these. These may be testable material. This criteria may be testable for ICM, so definitely check with that professor, see if they want you to know that. But for my exam, you don't have to worry about it. And I just put it in here because some of these medication recommendations are based off the IPSS score. So first off, we have a nice little table for initial monotherapy. We're going to go start with the alpha-1 adrenergic antagonist, alpha blockers, aka alpha blockers, the ABs. So you can put a number 1 up here. These are going to be your first line monotherapy for majority of your patients, and again after their lifestyle modifications. So definitely go ahead and read through this, just kind of what I said. Here is the list of the medications that have been approved by the FDA. As far as efficacy is concerned, they haven't been as a lot of head-to-head studies, but they all seem to be similarly efficacious, and it's going to be based on other reasons that you choose them. For example, cost, side effects, especially hypotension. So definitely put a star by that. Make sure you know that these medications can cause hypotension, which can be detrimental because you're typically with these patients, you're typically talking about older men. And so they may be on other antihypertensive medications, and so there can be some synergy there. Orthostatic hypotension can be an issue. And then also with the elderly population, you don't want these old men to be falling because they have orthostatic hypotension, for example. And then medication interactions. Again, elderly men, they are a higher percentage of them suffer from erectile dysfunction, which we haven't talked about yet, but the phosphodiesterase 5 inhibitors are a big player. Sorry about that. Unprofessional. I forgot to silence my phone. I'm on an unprofessional roll right here, so apologies. But the phosphodiesterase 5 inhibitors are a big player in erectile dysfunction. We'll be talking about those. And so there are potential drug interactions with these alpha 1 blockers and the PDE5 inhibitors, which is the abbreviation for those. And that they can have an increased risk of hypotension. So please note that. That's on some other slides, and you'll see that in the erectile dysfunction lecture, and you'll be hearing me talk about that again here. The other thing is, too, that some of these alpha-1 blockers are more uroselective. So we have the list here, and those actually have less hypotension, so that could be a benefit and an advantage to prescribing those. So that's what you see a lot of prescriptions for the tamsulosin, for example. One thing to note that we did talk about these alpha-1 blockers before in the cardiovascular module. Prazosin is a short-acting alpha blocker. It should not be used for BPH. The reason why it requires frequent dosing and it has potential for more cardiovascular side effects. So that is one where, like I said, they're all pretty much created equally, but probably want to go and stick with these uroselective ones that have the less risk of hypotension. And then there's also the selective alpha-1D antagonist, naftopidil. It may be effective, but that's just kind of the jury's still out. We're not really sure yet on that one. With these medications, you start low and go slow. What does that mean? You initiate at a low dose and you titrate up. We have it here on this table for the different ones you may be selecting. So I mentioned that tamsulosin gives you the titration, but and you could go with any of these if you wanted to out in your practice when you have your license, because you can do what you want. No, when you have your own license, but you do not need to memorize these titration schedules. Just know that they are out there, but please know for testing purposes that you do need to start low, go slow, meaning initiate at a low dose and then titrate up. Also note too that these medications, specifically terazosin and doxazosin, generally need to be initiated at bedtime. So this will help with the orthostatic hypotension and reduce that. So if they have the postural lightheadedness, it's they're laying down because it's right before bed, and so anyways, that may be something to think about. The other thing too is that when you are titrating up, you need to be mindful of adverse effects. And if it is well tolerated, the patient isn't having issues, you can increase. But if the person is having issues and they are having problems with adverse effects, and particularly hypotension, you may want to back off or not increase the dose, or maybe switch to a different class. Again, it's going to depend on the patient. The other thing to note too, that it may take up to 2 weeks before the benefits start seeing before the patients start seeing the benefits, especially if you are titrating your medications. So have your patient be patient. Patients be patient. Yeah, I said that correctly. Have your patients be patient, and give them up to a couple weeks for the titration. And there you go. There is that. I would read the fine print here. It just kind of reiterates some of the things we talked about. But as far as memorizing the specific dosage titrations, that is not going to be required, but definitely know that you do need to titrate, and then starting at bedtime may be advantageous. So the other thing to note too, that with titration, that you will need to re-titrate the medication. So for whatever reason, if the patient stops taking it for a month or so, a few weeks, or more than a month, that they will need to be re-titrated. Side effects, so definitely put a star here. Definitely want you guys to know hypotension. So most important side effect, and I mentioned why, that the hypotension, dizziness is going to be, for any medication, it's more of a serious issue, excuse me, more of a serious issue for your elderly population, which in general, again, make a stereotype about your BPH patients in the future. They are going to be typically older men. So having said that, we mentioned that some have lower potential to cause hypotension and syncope. So these may be ones that you'd want to stick with, especially with an elderly person that you already maybe has issues with it. The tamsulosin too has slightly less effect on blood pressure. So even out of these, the tamsulosin may be something to start with. I mentioned that they need to be they need to be initiated bedtime, some of those. Because of the blood pressure concerns, all patients that are on these need to be carefully monitored. And so it is, yes, for older men, but for all of them, go ahead and look through those. The other thing you should be mindful of is that these alpha-1 blockers may increase the incidence of heart failure if they're used as a monotherapy for hypertension. So just going to kind of a shout out back to your cardiovascular module, you'll remember that these aren't preferred to be used as monotherapy. However, there is some rationale to these being used if someone has hypertension. So again, with monitoring that caveat, the hypotension adverse effect of this can be advantageous. Again, if it's an older man who is on another antihypertensive and you're thinking about increasing their antihypertensive medications, an alpha blocker may be a reasonable choice, or rather there'd be a rationale to use it if the patient had BPH in combination with hypertension. So that's definitely something to look for for testing purposes. If a person has, the BPH plus HTN, definitely these should be considered, not necessarily as a monotherapy, but in combination with other antihypertensive medications. So hopefully that's clear. So it's one of those instances where the side effect can actually be beneficial, again, for a patient who has hypertension, but like always, where was it? Careful blood pressure monitoring is required in all patients. So know that for all the alpha blockers. Drug interactions, so definitely put a star here. Want you guys to know about the phosphodiesterase 5 inhibitors. And so basically this combination has a synergistic effect and can cause hypotension. It doesn't mean that these can never be used. And like I said too, older men with BPH may have problems with ED, erectile dysfunction, so you may be prescribing these erectile dysfunction medications. And so, you can do that. And we're going to talk about it a little bit, there's a phosphodiesterase 5 inhibitor, the tadalafil, that actually has FDA approval to help treat BPH. So again, if your elderly patient has erectile dysfunction and BPH, may be a reason, or rather you'd have a rationale to go with something like a PDE5 inhibitor, which is phosphodiesterase 5 inhibitor. So anyway, go ahead and read through this and just know that the dosing can have an effect too. So your lower dosing, less hypertensive effects, etc. But read through all of that. Another adverse effect, and I mentioned this too with elderly men, they already may have an issue with this, but ejaculatory dysfunction. So sexual dysfunction, unfortunately, can be an issue with these medications. So something to counsel your patients on and to be mindful of. And then so anyways, just let them know, because the patients usually don't like this and they will complain about it. Other common adverse effects: headache, dizziness, and nasal congestion. Those are common ones. Rare but serious one: intraoperative floppy iris syndrome during cataract surgery. So that's a rare but serious one. So please note that for studying purposes. Second line therapies, second line medications. We're going to go with the 5 alpha reductase inhibitors. This is a nice table. Thank you, UpToDate, because they put them in order. So you can put a number 1 by this for first line, second line, 5 alpha reductase inhibitors. And we will stay tuned for the rest of the story. So it's first line, second line, and the anticholinergic, spoiler alert, are going to be your third line. The beta-3 adrenergic agonists are not actually in the current guidelines, but we will talk about those. And then the PDE5 inhibitors are going to be more like third line too, depending on your patient. And it's going to be specifically those patients that have erectile dysfunction and BPH. So back to the second line, we have the 5 alpha reductase inhibitors. So these are ones that patients who cannot tolerate or are allergic to, or for whatever reason can't, handle the alpha-1 blockers, you will start with the 5-alpha reductase inhibitors. And then also these patients that do not have predominantly irritant symptoms, which I have listed there, or patients who do not have the erectile dysfunction, you can then start with a 5-alpha reductase inhibitor. These medications can take up to a year to sufficiently reduce or improve symptoms. So that's something to be mindful of. And again, definitely something to let your patients know that it may take 6 to 12 months. These are also advantageous for men who have a larger prostate, so you can note that when studying. So we have 2 medications in this. We have the finasteride and the dutasteride. We have the brand names there. As always, don't worry about memorizing the brand names for my exam, but they're there just because you may hear Proscar and Avodart maybe used more. So we have the dosing here. These do not require titration like the alpha blockers, but they may take longer, like I said, up to 12 months to start working. Adverse effects. So there were some issues about, or rather there were concerns with prostate cancer. And so they initially thought that these caused prostate cancer. Long story short, they found that they did some more research and they found like it wasn't really that warranted of a risk. However, the FDA still requires that these other urological conditions are assessed, including prostate cancer. So anyway, so that's where that comes from. So go ahead and read through these. So this is something you need to be thinking about in charting and make sure you're documenting that it is something you're mindful of because of this historical concern with prostate cancer. Sexual dysfunction, unfortunately, again, is a adverse effect you have to be worried about with these 5-alpha reductase inhibitors. The PSA concentrations may also decrease. So that's just something to be mindful of if you are testing a patient's PSA and they're on one of these medications. Know that the medication itself may be causing the decrease. There historically too were some concerns about bone loss. Well, long story short, it turns out that it doesn't cause loss of bone. But anyway, so you may hear that, or patients maybe are still concerned about that. Third line, we have the anticholinergic agents. So these are patients who have primarily irritative symptoms. If they have OAB, overactive bladder, without the increased PVR. These can also be used in combination with the alpha blockers if needed. So we have these here, the anticholinergic agents, which we'll be talking about more later in this module, but so we're coming back to those. But these are third line for the BPH. A big reason why they're not first or second line is because of adverse effects. So definitely put a star by that side. Adverse effects, put a star here as well. I want to make sure you guys know these anticholinergic adverse effects. Please study those. Make sure you know them for testing purposes. And then the contraindications here. So definitely a concern with those. One of the strategies to mitigate that is to use a low dose, short acting. So for example, tolterodine 1 milligram twice a day. So you notice that one is right here, which is Detrol, or Detrol LA, which is Los Angeles. No, I'm kidding. Detrol long acting is what Detrol LA is. So that may be an instance to do something like that. The short acting one, twice a day. PDE5 inhibitors, I mentioned that these are not, first or second line. They may have, and rather they should just really be limited to those patients who have erectile dysfunction. So specifically the tadalafil is one that has FDA approval for BPH, but again, not first line. So I'm going to read through that. Please note with this that you do need to be concerned with the renal function. So it shouldn't be prescribed if a person has creatinine clearance less than 30. Excuse me. And then we talked about before the drug interactions with the alpha-1 blockers, specifically hypotension. So there is the list. Again, we notice here we have the beta-3 adrenergic agonist, which we're not going to talk about just quite yet. Sorry, bad segue. You can do combination therapies too. So hold that thought with the beta-3 adrenergic agonist. We will be talking about it here in a little bit, but not just yet. You can use combination, and so it's going to depend on the patient. Alpha blocker plus 5-alpha reductase inhibitor is a strategy you can go with. But go ahead and read through this. You can do the anticholinergics and combinations as well. Herbal therapies are popular depending on your patient population. For me, it just kind of depends on what part of the country you're at, what pharmacy I'm at, or whatever. But so sometimes these are really popular, sometimes they're not. Take home point is that they basically need more research to be done. These haven't been studied enough. And so that is something that they're not considered first line, second, or third line on here, but they're out there. And there is some maybe promising evidence, some conflicting evidence. Go ahead and read through this. Saw palmetto is a really popular one that I get asked about in the pharmacy a lot. But as far as the studies haven't really shown, excuse me, great evidence out there. And like I said, kind of take home point with all these herbal therapies is they need to be more research done. And like I've gone over with you guys before, with all herbal therapies, they are not FDA regulated. So you do need to make sure that your patients are getting a credible source. And like I said, NSF, USP, or some third-party labs that will verify the ingredients in some of these herbal medications. Now we have the beta-3 agonist, as promised. Miragbagon. The generic from Ibertique, brand name here. This is, we haven't talked about this one before. It's kind of in its own little corner of the pharmacological universe, I guess. It is a beta-3 agonist, so it is used. I'm mentioning it in this presentation because it was listed on the table, but you notice its use is for overactive bladder with symptoms of urinary frequency, urgency, urinary incontinence. The mechanism of action, it's like its category, it's a beta-3 adrenergic receptor agonist, so please read through that to see specifically why it's advantageous. Concerns related to adverse effects, we have angioedema is a concern, a rare but serious adverse effect, and then the blood pressure effects. So it's not recommended in patients with severe uncontrolled hypertension. Let's read through that. Disease-related concerns, read through these as well. You know, hepatic impairment can be an issue, and renal impairment, as well as a rare but serious, but you need to be thinking about QT prolongation. So this medication with other medications that can cause QT prolongation could be bad as far as them causing arrhythmias. Summary recommendations, I will let you guys just read through those. As always, thank you guys for your time and attention. I appreciate it. Please feel free to email me comments, questions, or anything about this presentation that you'd like to let me know. All right, I'll talk to you guys later. Bye.